CARTITUDE-1, or J&J 4528, now known as ciltacabtagene autoleucel, or Cilta-cel, is a structurally distinct second-generation chimeric antigen receptor T-cell therapy with two BCMA binding domains. Today, I'm going to talk about the initial results from the CARTITUDE-1 study, which is the combined phase 1b and phase 2 portion of the study. CARTITUDE-1 consists of two portions. The phase 1b, which the primary objective was to characterize its safety and confirm the recommended phase 2 dose as inferred by the LEGEND-2 study, but in a slightly different population. The primary objective of the phase 2 portion was to evaluate its efficacy. Some key eligibility criteria required for the study is that patients had to have progressive multiple myeloma per IMWG criteria, have good performance status, and have measurable disease. In addition, these patients also had to have 3 or more prior therapies, be double refractory, and been exposed to a PI, an IMiD, or an anti-CD38. In the CARTITUDE-1 study, we treated a total of 97 patients with a median age of 61 and a little more than half were male. 13% of these patients had extramedullary disease. And you can also see that these patients are quite heavily pretreated, as their median prior lines of therapy was 6, and it ranged anywhere from 3 to 18. These patients are also heavily pretreated, and you can see that they're 100% triple exposed, 84% penta exposed, 88% triple refractory, and 42% penta refractory. Another thing I wanted to mention on this study is that you were not required to be refractory to your last line of therapy, but you can see that 99% of these patients were indeed refractory to their last line. Next, we'll discuss the safety data of this study. The most common adverse event, grade 3 or higher, was hematological. The median time of recovery of neutropenia was 2 weeks, and thrombocytopenia was 4 weeks. Patients with late recovery of grade 3 or 4 cytopenias, particularly neutropenia, was about 10%, and thrombocytopenia was about 26%. The most common complications you expect with CAR T-cell therapies are cytokine release syndrome and neurotoxicity. So let's talk a little bit about the cytokine release syndrome. All but 5 patients had CRS, with 95% of the CRS being mostly grade 1 and 2. You can also see that the median time of onset of CRS is about 7 days, with 89% of these patients having CRS at day 4 or later, and 74% having CRS at day 6 or later, opening the possibility of outpatient administration. Neurotoxicity is another known complication associated with CAR T-cell therapies. The total CAR T-cell neurotoxicity rate seen with Cilta-cel is about 21%, with about 10% having grade 3 or higher. These CAR T-cell neurotoxicities can be further classified into 2 groups, ICANS and other neurotoxicities, with significant overlap between these 2 categories. The 16 patients who had ICANS had complete resolution of their symptoms, and it was mostly grade 1 and 2 ICANS. The 12 patients who had other neurotoxicities actually happened after resolution of their CRS and/or ICANS. 5 of these patients had movement or neurocognitive changes, while 7 patients had symptoms of nerve palsy or peripheral motor neuropathy. These neurotoxicities resolved in 6 patients, while in the other 6 who did not resolve, 1 patient still has ongoing low-grade neurotoxicity, 1 died from complications of neurotoxicities, and 4 died from other causes, particularly sepsis and respiratory failure and a lung abscess. Now let's talk about the efficacy of this data. The overall response rate is 97%, with 67% stringent CR and 93% VGPR or better. We saw how heavily pretreated these patients were, and to see a one-time treatment give these kinds of response rates is quite exceptional. What's even more impressive is that 72% of these patients are still maintaining their response at the time of data cutoff. We also know, based on the Mammoth study, that patients with relapsed refractory myeloma have a median overall survival of 9.2 months if triple refractory and only 5.6 months if penta refractory. In this study, we know that the median PFS is at least a full year, and we still haven't even reached a median PFS after a median duration of follow-up of 12.4 months. We also tried to break the PFS down by response, and we saw that the 12-month PFS rate in patients who achieve CR or better is 85%, and the 12-month PFS in patients in VGPR was 68%. Once again, the median PFS was not reached in either group. So in conclusion, we saw that Cilta-cel has a manageable safety profile at the recommended phase 2 dose of 0.75 million CAR T cells per kilogram of body weight, with 95% of the patients having mostly grade 1 and 2 CRS. Neurotoxicity of any grade was seen in about 21% of the patients, with grade 3 or higher being only 10%. We also saw early, deep, and durable responses with this heavily pretreated patient population, with an overall response rate of 97% and stringent CR rates of 67%, with 72% of these patients still maintaining their response at the time of data cutoff. We also saw that at the time of data cutoff, the 12-month PFS was not reached. We know that cilta-cel is currently being investigated in earlier line settings and as an outpatient administration in our CARTITUDE-2 and 4 programs.